This year, the symposium is going to focus on creating high reliability care across the continuum. And so I'll be back in a moment to talk with you about the great other speakers that we've got here. But it's really been rewarding for me to get closer to this state and to watch the kind of improvements that you've been making. As I travel the world, as I travel the country, there isn't another state that's come together like you have with ambitious aims across the entire continuum of care, and with the depth from boards of trustees, members of boards who are here today, to frontline physicians and nurses who are taking care of patients every day. That scope that you've approached is just breathtaking to me. Last year, when I was here, I had the privilege of announcing the creation of the South Carolina Partnership for Health, which includes Blue Cross Blue Shield of South Carolina, Health Sciences South Carolina, and the South Carolina Hospital Association. And the purpose of the partnership is to join forces across the state to bring the best knowledge to bear to produce better health, more reliable health care for every citizen in South Carolina. This year, I've got a great pleasure to announce the kickoff of the partnership's initiative to improve healthcare transitions. And I love looking at the breadth across the banners here at the front. Later today, Dr. Eric Coleman is going to talk about a major learning collaborative here in the state, working on unnecessary readmissions and getting patients safely in the care site that they most need. We'll also hear from Dr. Atul Gawande on the work that he's been doing here in South Carolina on improving surgical safety. And we'll hear from Dr. David Marks on A Just Culture, the father of A Just Culture. And of course, no patient safety symposium would be complete without hearing from a patient. And we're not only going to hear the voice of a patient and family member, but we're going to see images created here. I'll be back with you in a moment on that. But let me talk a little bit to open the session on, can we go to the front of my slides? Thank you. I want to talk about an experience that I had last week. Last week, I was in Paris, France, and I was at the IHI International Forum. We run one each year, usually in Orlando in the United States, and then one internationally, someplace else in the world. And this is the last one, so can we go to the first one? And so I was in Paris, France, and when I introduced my slides, it was the largest one we've ever had. We had 2,800 people here from 80 different countries. And so there were people from many countries across the world. And here's how I opened my slides. I opened my slides talking about you. And I talked about the fact that you've made some great progress in this state over the last years. You've made incredible progress in working on safety, in working on care for patients in nursing homes. You've made strides in care transitions, but you still had some very big gaps. And I talked about Richland County, and everybody, the 2,800 people, were talking about zip code, they call it postal code, 29203, and how you understand the gaps in that postal code, and that you were really recognizing what kind of care you wanted to provide here. And I can tell you the whole room, the whole meeting was abuzz with talking about that. And I explained that for the last several years, I've spent this week with you, and that together we were talking about the challenges of the people, particularly in this postal code, but across the state of South Carolina. And I said that in various breakouts, we were saying, should we provide more clinics in neighborhood pharmacies? Should we open access to get more patient visits? Should we provide more telephone consultations to patients? And that as we were struggling with the question, will more health care produce more health? I told them that I found the answer to that question really not in the breakout sessions, I'm sorry to say, but in this painting. And I shared the painting that Tim Floyd gave me a copy of last year at this meeting. Now, Tim calls this the edge of change. And what he described last year at this meeting was that healthcare, to him, looks like the bottom of the painting, like we're in little dark silos. And I named my forum plenary silos. And I said, we have care that's put into small buckets. A patient will go and see a physician about a hemoglobin level, and then perhaps go to see a nutritionist about a diet. But all care is still happening, for the most part, in silos. And what Tim said to me last year is that it's very dark. It's a dark and depressing place to work, and it's a dark and depressing place to get care. And then Tim drew that line, that jagged line across the middle of the painting, and he calls that the edge of change. And he said he's inspired by the work that's happening in this room. He said that is the quality improvement movement. He said what we're doing here is we're creating connections across the continuum. He said we're breaking down the silos and moving patients into continuous care. And that you can see that the top part of the painting is a whole different place to get care and to work. It's a place of sharing best practices. It's a place of stimulating and urging for us to close the gaps. And it's a place where we work together. And so it's brighter, and it's cleaner, and it's a happier, much more effective place to work and to give care. So I just wanted you to know you're famous. Everybody's talking about silos, about postal code 29203, about the edge of change, and about the need to work across the continuum. So I then talked about Healthy Columbia. And I said this year it wasn't going to be a group of healthcare professionals sitting in a room saying, can we get more visits, more silos? It was going to be the community in this room saying, what can we do together? It was really looking at the assets of South Carolina in a new way and saying, we cannot do this alone. We will never improve the health of zip code 29203 from within the healthcare silos. We will only do it when we break out of those silos. So I then challenged everybody to take up the challenge that you've taken. And I told them that the whole state here is talking about the IHI triple aim. That the whole state here, and it's the only state I know that really has adopted this in a wholesale way, is saying we have 3 obligations, not 1. And the first obligation we have is to work on the health of the population. The second obligation that we have is to improve the care, break down the silos, and start making care sane for workers and for patients. And the third is to work on cost per capita. We've got a social obligation to decrease the cost of health care so that we can provide education and infrastructure across our communities. Columbia, South Carolina as a state will never get to be healthy if we only focus on keeping healthcare costs as they are today. So I issued them a challenge. And I said, let's take a look at the progress going back. Let's celebrate that you've been going for the goal, and that across the state we're seeing improvements in safety. We're seeing improvements in access. They're not completely there yet. We're seeing tremendous new models of care being built, and we're seeing the patient's voice being heard in design. We're seeing some evidence of new technology. I was with George Halverson, who's the CEO of Kaiser Permanente a few weeks ago, and George, with great pride, pulled his cell phone out of his pocket, and he said to me, Maureen, this is my medical record. And he said, now George is my age, so he said, I have an app, and we were really kind of laughing about what's an app, but the students in the front rows here can help us with that. But what he said is that we've got to really think differently about using technology. And he said, this cell phone app on my iPhone is my medical record. He said, I get my lab results on it. He said, I can renew prescriptions on it. I can text my doctor. I can make appointments. My whole interaction with the healthcare system now is through the app on my phone. And so I think we're starting to see some progress, but we've got a long way to go. And I'm going to challenge us today and tomorrow to think about these 3 areas for improvement: at the patient level, at the organizational level, and at the community level. And I'm going to talk this morning about the patient level, and then tomorrow I'm going to come back and talk about the organization and the community level. But let me start us off today by saying the challenge I'm issuing to you is this. It's to take Susan Edgman-Levitan's challenge and that is to move the conversation at the patient level from a healthcare system that asks, what's the matter, to a healthcare system that asks, what matters to you? I've sat in physician practices a lot in this past year, and the whole of the healthcare system is built on what's the matter. What brings you here today? Is it your hemoglobin? Is your blood pressure out of control? Are you having trouble sleeping? The whole system is built on interactions around what's the matter. That's not the important thing. The important thing is understanding what matters to the patient. So I'm going to challenge you today to move from what's the matter thinking, what's the matter structures, to what matters to you. Another example from my colleague Muir Gray in England is to move from thinking that the patient is the problem. And so often when we look at our results and our outcomes, we say the patient is non-compliant, the patient is anxious, the patient doesn't understand, the patient is so ill that when he or she gets home, they can't manage their own health. And we look at our own failures as being the patient is the problem. We've got to move away from that and start to think together we can produce a better system. And my colleague Victor Montori from Mayo Clinic says that we need to design what he calls minimally disruptive medicine. And as I've sat with patients who have really seriously burdensome diseases, I've begun to think about it this way. If you look at a patient who's got diabetes as an example, and you measure what is the burden of that illness, you can even measure it in minutes, but you can measure how much of every diabetic patient's day is spent managing their disease. It's getting up and doing their blood sugars. It's texting their doctor. It's adjusting their medication levels. It's changing their diets. It's getting appropriate exercise. There's a burden of disease that in many cases we can't manage, but we can manage the burden of the treatment. And that's our job, is to make it easy for that patient to be able to take the best care of themselves that they can. And I want to push us on goal setting. And I think you might think, well, goal setting, that's pretty easy stuff. More and more, I'm seeing peer-reviewed journals like the New England Journal of Medicine recently devoted a whole section to patient goal setting. What I'm finding, though, is most often goal setting isn't sincere and it's not real. Just last week, before I headed for Paris, I spent a morning in 2 Boston academic medical centers. On the one hand, my first visit was to one of my fellow at IHI's young daughter, who was a patient at a pediatric hospital in Boston. And I watched with great pleasure goal setting happen. There was a whiteboard in her room. This young child had a devastating illness. And I watched the doctors and the nurses, the residents, come in as a team with the therapist, play therapist, and they stood around the bed with the family, and they said, let's figure out what's going to happen today. Now, first of all, let's worry about pain. How are we going to manage her pain? Let's try this. And everybody agreed, goes up on the whiteboard. Let's talk about her diet. She's been on liquid diet. Let's see what we can do today to advance that diet. Let's talk about the sequence of tests and care. We'll bathe her now. We'll get this test in the morning and this test in the afternoon. And let's talk about mobilization. We'll see if she can walk to the playroom this morning, and if she does well, then we'll try it again this afternoon. They even talked about her potential discharge, which wasn't on the horizon, but it was planned for with this multidisciplinary team. It was an amazing experience to watch people together build the course of the day and then beyond. And then I traveled across town to another academic medical center to visit my brother-in-law, who's suffering from ileostomy, colostomy, and a lot of other very difficult diseases. And I watched no patient goal setting. I watched the resident walk in, and my brother-in-law, who hadn't had anything to eat for 2 weeks, say, I am so thirsty, I really need something to eat. And the resident said, well, I'll put you on a clear liquid diet. As the tray came, the nurse came and took it out of the room and said, you're NPO. The medical student came in and said, here, you can have orange juice. And the nurse came and took it out of his hand. I watched the nurse say, I can get you up and walk you. He got halfway down the hall, and the medical student said, you need to go back to bed. I watched his confusion because one physician came in and said, take enough pain medication to keep you comfortable because that will allow you to mobilize. And I watched the very next physician come in and say, the more pain medication you take, the more constipated you're going to be, and you're never going to get out of here. Nobody would tell him when he was going to go home until he walked in. The physician walked in one day, and my brother-in-law was in a devastating clinical condition, and the surgeon lifted up his Johnny, looked at his wound, and said, "You can go home today." And my brother-in-law said, I can't manage my colostomy. I can't manage my urostomy. There's nobody at my house. I haven't eaten. I've had no training on how to care for my wound." And the doctor said, no, you can go home. Within a half an hour, he was in a wheelchair going down the hallway. There was no goal setting. I watched also, with some interest, people not focusing on the assets of the family. And I borrowed a kind of a metaphor from the social scientists. The social scientists called ABCD. They call it asset-based community design. And I'm saying we need to understand asset-based care designs. We need to know what the assets of the patient and the family are so that we can produce much better care. Goal setting is now being proven in the journals to be producing better clinical outcomes at a lower cost. And yet we're not listening to the patients. So I bring you back to William Osler and his quote on, "Listen to your patient, they're telling you the diagnosis." And as I sat in the ostomy unit with all of these patients, it was a group of men who were all trying to figure out how to manage their ostomies. I watched a physician come in and talk to one of the patients, not my brother-in-law, a different patient. And the patient said, "I'm having a lot of trouble with my ostomy." And the physician started writing medication prescriptions. And the patient said, "All I need, doctor, is scrambled eggs and a cup of black coffee." And he said, no, and he kept writing medication prescriptions. And the patient said, "Look, I know myself. Give me a scrambled egg and I'll be fine." And finally, it took about 20 minutes for that physician to come around to prescribing a scrambled egg and a cup of coffee, which worked beautifully. It always has, it always will. The second patient said, "Here's what I do." He said, "I get in a hot shower and I turn my back and I have hot water on my back." He said, "It manages me every time." And a third patient with the urostomy said, "All I do is I stand in front of the sink and I put my hands under hot water." They had assets to manage themselves that were ignored in the clinical system. Every single clinical intervention was about medications or x-rays. And so we really need to get back to thinking about what is the patient telling us? How do we begin to mobilize the assets that the patient and the family bring? Because until we do that, we're not going to make the kind of progress we need to. We're seeing these kind of goals produce great results when we listen to the patients. And I'll end my talk this morning on the patient piece of this by telling you another story. Recently, I was in La Crosse, Wisconsin, and I was sitting in a hospital, and I was talking about continuity of care and how do we take care of patients across the continuum? How do we understand the assets that they bring? And I said to the nurses there, "Introduce me to a patient. Tell me about somebody who you're taking care of today." And they introduced me to a patient who's 95 years old. Her name is Ethel. And last summer, Ethel's husband died, and Ethel has no family left. So she was living by herself, and she was deeply grieving her husband's death. And so she kind of stopped eating and got weaker and ended up totally immobilized in her home. As that happened, week after week, more and more nursing assistant care and nursing care was prescribed, and pretty soon Ethel was almost 24-hour-a-day home care. In the morning, the home care aides would come in and they'd bathe her, and they'd feed her, and they'd put her in a wheelchair, and they'd put her in front of the television, and her life was just dwindling away. And one day, one of the nurses said, not "What's the matter, Ethel?" but "What matters to you?" And Ethel said, "I want a dog." And the nurse said, "No, I'm from healthcare, and Ethel kept saying, "I want a dog." And the nurse kept saying, "I'm from healthcare." And after a couple of weeks, what happened was the nurse, on her way to visit Ethel, stopped at the dog pound, and she picked Ethel up a dog. Ethel, within weeks, was walking 150 steps unaided. She needs hardly any care at home. And now 3 mornings a week, Ethel goes to the hospital and plays the violin for other patients in the lobby of the hospital. Here's Ethel and her violin, and her dog. So we have a long way to go, I think. Tomorrow, I'm going to spend more time with you thinking about what in your hospitals or your practices can you do to break out of the mold of thinking we're stuck in the silo. I'm working on your interaction. How can we begin to understand Ethel and her assets and build on those assets? Because it's a lot cheaper for Ethel's dog food than it is for 24-hour care. And her life has meaning again. And then I'm also going to talk about the community. What assets do we have here in healthy South Carolina, healthy Columbia, that we can bring to really break down those silos and use every asset we've got here? So let me just wrap up my remarks this morning by introducing a great friend and a colleague, Regina Holliday. I am so pleased to introduce Regina to you. If you were visiting IHI today, you'd see one of Regina's pieces of art hangs on my door. So every morning when I walk into work, the very first thing I see is Regina's work. Regina is a Washington, D.C. based patient rights art advocate, probably the only one I would think in the country. But she began her work painting murals to kind of work through the death of her husband, Frederick Allen Holliday II. He died June 17th in 2009 from kidney cancer, and I remember the first time I met Regina talking with her about the great challenges that she had in trying to create a continuous care system across his 5 facilities that cared for him before his death. After she worked through her husband's death, she created a mural called 73 Cents, and I'm hoping, Regina, that you'll describe why you named your first painting 73 Cents. But her family journey has become a national treasure, and every news journal from across the country, ABC, CBS, BBC, and even the British Medical Journal have featured Regina's work. She also paints at conferences, and she's been visiting IHI many times to help us to learn through her eyes. So I will help welcome Regina Holliday.